Right, cranial nerves. I'm going to get you guys a little bit more involved here now. I haven't got any sweets like Janae. Maybe have you got some up there, Janae? Any sweets for me? Throw? No, okay. First of all, learn the nerves. Please, please learn the nerves. Okay? There's nothing worse than seeing people who like you go, oh yeah, fourth cranial nerve, and they're like, to touch, etc., etc. Okay? You've got to actually know the nerves now. Okay? And the way that you'll learn the nerves properly is by doing lots of examinations and by knowing and keep on going through what the most common pathologies are. Please, please, please. You should be able to, if I just go, what's 9? What's 11? You should be able to just instantly go like that. Okay? But you'll only get there through practice. So, first of all, who knows what causes loss of smell? Parkinson's. Who said that? Yeah, I can do. Most common cause? Flu. Who said flu? Good. Upper respiratory tract infection. Absolutely the most common. Okay? And importantly, that's temporary. Okay? So temporary loss of smell is nearly always upper respiratory tract infection. Now, permanent loss of smell occurs really in only 2 situations that you need to be aware of. It occurs with a tumour at the front of the brain, which is usually called a meningioma. And that affects the olfactory bulb, and you lose your smell. The other situation is in trauma. And the reason for that is the little nerve fibres that protrude from the olfactory bulb actually pass through the ethmoid bone. So any penetrating or non-penetrating trauma to the front of the face can actually shear off all of those fibres if it fractures the ethmoid bone. Okay, that's all you need to know about the first cranial nerve. Now, these are the really difficult ones, the cranial nerves of the eye. Cranial nerves of the eyes. Doesn't quite work, does it? But importantly, you should group them together and test them together. Now, there's lots of versions of this. This is my simple version of this, so I'm going to try and make it simple. I think there are 4 lesions that you should recognize in this pathway. Okay? You should recognize a lesion here, and you guys, if you want, you can draw in the little lesions if you want. Monocular, that causes monocular vision loss. So one of the eyes totally black. Okay? You can have a lesion here that causes bitemporal hemianopia. So both temporal fields are lost. You get one either in the optic tract or this bit further back called the optic radiation. That causes a homonymous hemianopia. And then finally, you can get a lesion at the back, like the occipital pole. And that also causes a homonymous hemianopia, but you get something called macular sparing. Okay? So those 4 lesions, commit them to your memories now. So what causes them? This is the next thing you need to remember. The easiest one is bitemporal hemianopia. Okay? Pituitary adenoma. Just makes sense, doesn't it? You've got a tumour sitting there, it obstructs one of the things, and you get this, bitemporal hemianopia. These ones usually aren't so obvious. Okay? For monocular, Rashmi's already spoken about one of them in the setting of temporal arteritis, where there's occlusion in the retinal artery. The other important one I want you to remember is demyelination, okay? Particularly in the condition of multiple sclerosis. Multiple sclerosis can present simply with loss of vision, monocular vision loss. So demyelination. The homonymous ones always think about vascular pathology. Okay? So if you see any type of that you think vascular pathology. And particularly the posterior stroke. Rashmi talked last week about the Bamford classification of cerebrovascular accidents, in particular the posterior stroke, which supplies or involves the occipital cortex, causes this homonymous loss, but with sparing of the macula. And the reason for that is there's actually there's 2 arterial supplies to that area. So if you block off one, it's still patent, so you still get macular vision. Okay? And then tumours as well. If you've got a big tumour sitting back here, then that can also affect the tract and radiation. Okay, that's it. Okay? Simple things. That's all you need to know about fields for now. The next thing is the pupils. Okay? This diagram looks very, very complicated. It's not very, very complicated. It's very easy, as long as you remember that the optic nerve is afferent, okay, and the oculomotor is efferent. Okay? So you get your optic coming back. It goes into this thing called the Edinger-Westphal nucleus, and then you get the efferent oculomotor coming out to control the various features that you see. So, pupil problems. They can either have dilated pupils or constricted pupils. Okay? There are two eponymous things you should know here. So, dilated pupils, something called the Holmes-Addy pupil or myotonic pupil. And that's usually a woman with a fixed dilated pupil who also is hyporeflexic. Those are the three features. Okay? Pupillary constriction is the so-called Argyll-Robertson pupil, okay, which indeed is caused by syphilis. And the exact, does anyone know the rather apt mnemonic for this? What happens if you shine a light on this eye? It accommodates, but it doesn't react. Exactly. And hence the association syphilis, prostitutes, accommodation, whatever. Okay. That's one way to remember it. So it accommodates, but it doesn't react. Okay. In terms of actual nerve lesions themselves, obviously, if the third nerve is the afferent bit, pupillary dilatation can be caused by a third nerve palsy. If the sympathetic supply to the eye is reduced, you get pupillary constriction. And the situation that you get this is in something called Horner's syndrome. Horner's syndrome is four things: ptosis, meiosis, anhidrosis, endophthalmos. Okay? That's not so important to remember. What it's important to realize is that lesions in the upper thorax and neck can cause problems in the eye. And the reason for that is the path of this sympathetic nerve to the superior cervical ganglion that comes up to innervate the eye. So you can have, for example, a Pancoast tumour, an apical lung tumour, that disrupts the stellate ganglion down here and causes a Horner's syndrome. The other common situation you see is after neck surgery. And after any sort of neck surgery here, you can get a Horner's syndrome. Finally, drugs. Okay? Most of the drugs that cause these things are eye drops, and the effect is totally intentional. But just to be aware that if you ever see the phrase pinpoint pupils in any situation, it's always because the patient's taken a heroin overdose, so opiates. So just remember that. Okay, these ones, the actual movements of the eye. Now, once again, this is something that's really difficult. But I think to start off, you should just try and learn about oculomotor palsies. Okay, the most common thing that you guys are going to see is going to be an oculomotor palsy. The most common thing you're going to get asked about is an oculomotor palsy. In terms of the principles, however, you should remember that if you take out one of these nerves, then the eye basically goes out of balance. If you take out one of the nerves supplying the various muscles, what happens is the eye tends to move with the other muscles. So, for example, in an oculomotor palsy, if you take out this one, and this one, what happens is you get unopposed action of lateral rectus and superior oblique. Okay? So the eye goes outwards and it goes downwards. Hence the characteristic oculomotor palsy causes a down and out eye. Okay? And that applies with all the other ones as well. So these ones are really, really uncommon. If you want to know three causes, the most common ones are probably tumours, MS, and association with infarction. But I don't think you should worry so much about that. The most important one is the third nerve, the oculomotor nerve. Okay? Oculomotor innervates all of the muscles except lateral rectus, which is 6, and superior oblique, which is 4. As we've already spoken about, and importantly also supplies the sphincter pupillae and controls the efferent limb from the Edinger-Westphal nucleus. And also this muscle as well, levator palpebrae superioris, but don't worry so much. 2 lesions that you need to know in oculomotor. You can get a medical nerve palsy of the third nerve, or you can get a surgical one. If you get a medical one, the pupil is spared. Okay, so the pupil is normal. If you get a surgical one, the pupil is involved and is blown open. Okay? Why does this happen? Essentially, the one surgical cause you need to be aware of is a posterior communicating artery aneurysm. Okay? And that's really, really rare, but it's the most common thing that causes it, so you should know it. And the reason you get that is if you have an aneurysm or something compressing, and this is my version of the third cranial nerve with vessels surrounding it. If you have a mass compressing the third nerve, okay, the fibers that supply the pupil aspect of it are actually in the center here. So if you get complete compression of that nerve, then the pupil is involved because that central bit is involved. Okay? In medical palsies, such as in diabetes, okay, where the problem is with the vascular supply around the outside, obviously if the vascular supply is reduced, the first bit of the nerve to be involved is going to be this superficial portion. Okay? And as that's far away from the bit where the pupillary fibers run, you don't get involvement of the pupil. That's as simple as I can make it, the explanation. And here's an example. If you think back to the original diagram, this is an intracranial aneurysm, posterior communicating artery aneurysm, which would cause a surgical third nerve palsy. Okay, I'm not going to talk about 5 because once again, you won't get pathologies. You won't see many pathologies of 5. You'll have to test for 5 in another setting I'm going to talk about in a bit. But isolated things with 5, very, very rare. 7 is really, really important, the facial nerve. Okay, what is this? Bell's palsy. Yeah, well, we don't know it's Bell's yet. It could be, and there could be other causes. Of which side? Left. Yes. Okay. So the features are drooping of the corner of the mouth. They get loss of this nasolabial fold here. And this diagram is a bit of they do get a droopy eyelid, but the problem is actually they often can't close their eye. Okay? Remember, facial nerve is muscles of facial expression. Patients with 7 lesions can't have difficulty closing their eyes. One of the most serious complications of having one of these lesions is not being able to close that eye. They can get ulceration of the cornea because it's open all the time. And often it'll have to actually be sellotaped shut or actually sometimes even sewn shut until the lesion has resolved. Facial palsies can be upper or lower. Important thing is with the eyebrows. That's how you tell the difference. Okay? If the patient can raise their eyebrows but they have all the other features, then it's an upper motor neuron. If they can't, lower motor neuron. And that's all to do with bilateral cortical innervation and all this kind of stuff. Not worth explaining, just remember it. In terms of causes, stroke. Upper motor neuron facial palsy is nearly always stroke. Lower motor neuron is nearly always Bell's palsy. Okay, Bell's palsy. But occasionally you see it in parotid tumours as well. And that's because the actual nerve comes down behind and crosses over the parotid. If you have a tumour there, it will affect the nerve as well. This is another version of Bell's palsy. Anyone know what this is? Gold stars available. Someone said it over there. Yeah, it is shingles, but specifically, you know what it's called? There's like two eponymous names. Called Ramsay-Hunt syndrome. Okay. Now, actually, I should have shown you a picture of the inside of the ear, because that's where you usually get these vesicles. Okay. If you get a question of a Bell's palsy or a lower motor neuron, 7th nerve, plus vesicles within the ear canal, called Ramsay-Hunt syndrome. Okay, we're nearly there. 8, vestibulocochlear. I only want to talk about the cochlear aspect of it. You guys all know about Weber's and Rinne's tests and all that kind of stuff. Essentially, with those tests, you're trying to decide, is it conductive or sensory neural? I've put this list here because no one ever seems to talk about this list. And I remember I always got asked, what are the causes of conductive versus sensory neural? And I always sort of forgot. Okay, but most common for conductive, wax, perforation of the eardrum, because you need the eardrum to actually amplify sounds coming in through the external auditory meatus. Chronic otitis media, because essentially you get thickening of the eardrum, so it's less able to amplify. And in otosclerosis, which is essentially where you get sclerosis of the three small bones in the middle ear that are involved in amplifying the sound towards the round window that communicates with the labyrinth. Sensory neural loss, you're thinking about problems with the actual machinery itself inside the ear. Age is probably the most important, the most common cause for this. Tumours, acoustic neuromas, yes. Infection, particularly meningitis. We were actually speaking earlier about using steroids to prevent complications of meningitis. Okay, this is one of the things that steroid can do, is to reduce the incidence of sensory neural hearing loss after meningitis. There's a condition called Meniere's disease, which I don't want to talk about, but you should know something about. And then finally, drugs. Okay, gentamicin is a drug that can cause severe sensory neural loss. Finally, once again, I'm grouping nerves together. Okay, you can get isolated lesions in 9, 10, 11, etc. But it's really useful to link these together because they tend to cause, when they're affected, the same sort of groups of symptoms. So 9 to 12 are called the bulbar nerves. They're called the bulbar ones because they all come from the bulb of the medulla. Isolated lesions are rare. If you have lesions in these nerves, you tend to get two features. You tend to get dysarthria and you tend to get dysphagia. So you have problems articulating and you have problems swallowing. Swallowing is an incredibly complicated process involving all the different nerves at all the different stages. And if that is affected in any way, then the whole process basically goes kaput. So if it's an upper motor neuron problem with these nerves, you get something called a pseudobulbar palsy. If it's a lower motor neuron, you get a bulbar palsy. The features of a lower motor neuron bulbar palsy are wasting. Okay, remember, wasting, one of the key features of any lower motor neuron lesion, and you get fasciculation, another key feature. And that, once again, it looks like bags of worms or little worms underneath the skin. You actually see it in the tongue. And importantly here, the reflexes are normal. So the jaw jerk, which is cranial nerve number 5, the trigeminal, is normal. And that's consistent with a lower motor neuron pattern. In a pseudobulbar palsy, the tongue is small. It's described as small and spastic. I've never really seen a small or spastic tongue, but that's the thing that will be spoken about in the EMQs. Okay, the important thing is there's no fasciculation. The tongue won't be fasciculating. Some of them also get this feature of emotional lability, and I'm sure that's due to more complicated supratentorial effects of these sorts of lesions, but that's another characteristic feature of pseudobulbar palsies. And importantly, as it's an upper motor neuron lesion, they get an exaggerated jaw jerk. In terms of causes, these are the causes. Okay? We'll start with the bulbar. The one that I think you should certainly remember is motor neuron disease. We haven't talked really about motor neuron disease, multiple sclerosis, any of these particular conditions. You certainly read something about them, particularly motor neuron disease. Does anyone remember what I said is the key feature of motor neuron disease? Mixed pattern, yeah. So you get both lower features and upper features together. If ever you see those two things occurring, always think motor neuron disease. You also get bulbar palsies in this thing called syringobulbar. If ever you see syringo, okay, it basically means fluid-filled space. So syringobulbar, syringomyelia, essentially you get fluid-filled spaces in the spinal cord. Okay. You either get them in the cervical spinal cord, which is syringomyelia, or you get them in the bulbar region of the medulla, which is syringobulbar. Okay. And that can also cause lower motor neuron pattern. And then finally, Guillain-Barré can also do it. Once again, pseudobulbar upper motor neuron, stroke is really common, and the other situation is multiple sclerosis. Those are the two ones you need to remember.